Thank you very much, Dr. Fadke. So I've been sitting here in the audience and listening to stories and stories. I think pathologists are fantastic storytellers. And I think if all of us were to write a book, it will make an interesting read. So this is the topic of my thing, that as pathologists, our life is never smooth. One day we are on this curve, then we have to take a bend and take a U-turn and go to the other road. So over 30 years, Swapnil said you can talk about anything you want, and if I do that, then I'll take the whole day. So what I decided is, let's me focus on common areas, because I like storytelling as well. So I will just discuss 4 things, namely papillary tumors, epithelial proliferations, unusual histologies in breast, biomarkers in invasive cancer because people take them for granted, and lymphoid lesions in the breast. So the spectrum of papillary tumor is very easy. It's papilloma and papillary carcinomas. And we have a whole bunch in between of epithelial proliferations, which could be nothing. They could be atypical ductal hyperplasia, and they could be in situ carcinoma. Now, in my entire career, I have seen these are the maximum cases for reticulations, and we've heard stories where pathologists have lost their careers because they are unable to distinguish this. So epithelial proliferations in papillary tumors are dealt with in the same way as we did with any intraductal proliferations. So Dr. Borges has told to us about clonality. So it's very simple that in an epithelial proliferation, if all cells share the same cytokeratin, then it's likely dangerous. If it is a mixture of epithelial and myoepithelial keratin, then you're probably looking at a little more benign entity. So what we do normally is we do a high molecular weight cytokeratin, or CK5-6, and CK8-18, and then we decide 8-18 is the luminal cytokeratin, 5-6-14 are usually the myoepithelial cytokeratin. So we do these markers, and then we decide how we go forward. Few other markers also are important, and what I use is the ER alpha, and I use cyclin D1 generationally. There are many more molecular markers, but I'm not going to deal with it because this is not commonly used in practice. So the ER alpha in the low-grade lesions is always 100%. It is not there in the benign lesions. It is not there in the high-grade lesions. But in this intermediate and low-grade category, it's 100%. The same thing with cyclin D1, it's exactly the same. So these 2 markers can be used in routine practice. Now what people don't understand is papillomas get irritated very fast, like all of us, I guess, and there are 2 types of proliferations. In one proliferation, you have a papillary proliferation. The spaces in between get filled by myoepithelial cells. So it starts looking very solid, and you can see the images on that other side, that they're looking very solid, and this tumor came to us actually as invasive breast carcinoma because it looked like that. Another type of proliferation which is mistaken for invasion in a papilloma is that in the core of the papilloma, you will see acinar structures with atypia because they are often apocrine, and they are called as invasive, whereas it's nothing but an adenosis-like growth pattern. You can see a papillae, and in the stalk, you are seeing proliferation of structures. Now, why are we worried about papillomas? Besides that they produce nipple discharge, the first paper in 1981 by Murad said that most patients with papilloma, at least 6 out of 21 in his series, developed invasive breast carcinoma. The literature recently is not so bad. We know that if there is no atypia, you don't have to worry about a papilloma. If there is an atypia, or if it is multiple, even if it is without atypia, it carries an increased risk of cancer. So remember, multiple papillomas are the dangerous ones. A solitary papilloma, what it told us is that solitary papilloma, you might go down on the atypia a little bit, but multiple papillomas, you cannot leave them alone. So problem is that there is a Tavasoli, there's a SNIT, there's a WHO, and they come together and make their own definitions without having robust data, and we are at the end of it. So there is no universally accepted definition for when to call something as ADH and when to get DCIs. And it's natural because actually they're one and the same entity. Only when it is overwhelming, we call it DCIs, and when it is not overwhelming, we call it ADH. So molecular-wise, ADH is equal to most DCIs. So what the WHO recommends, and if you are fond of quoting WHO, yes, if you have an atypical ductal proliferation, which is high or intermediate grade, then you call it DCIs, irrespective of the size. If it is low grade, then look at the size. If the low grade is greater than 3 millimeter, then you call it DCIS. Now the problem is nobody knows where this 3 millimeter came from, except that page in this particular article mentioned it, and we are just carrying out this magic number forward. So today we have some molecular markers that we can do to say that, okay, this is papilloma, this is ATH, this is DCIS. Interestingly, benign papillomas carry PIK3 mutations. 70% of them carry mutation. And loss of PIK3 mutation is associated with high risk for progression to invasive cancers. Papillomas carry the loss of 16q and 7q, whereas if you have 1q and 11q abnormalities, then it is likely to progress to cancer. So I have not used this. In one patient, we have done a PIK3 mutation, but it was not of much help. The moral of the story is, if you are in a privileged laboratory, please go ahead and do it. So we'll look at 3 cases quickly, and we'll see. So this is a 55-year-old lady who was operated at one of the local hospitals in Mumbai, and she had a diagnosis of complex papilloma with DCIS. Because she heard the word carcinoma in a report, she said, I want mastectomy, I don't want this. This patient, somebody was in Tata, so he submitted the slides for review. And this was the lesion. Now, in papillary lesion, the one thing that you do is look at all those fragments of fronds that you see, they should fit like a puzzle. If they fit like a puzzle, I don't worry about it. If you can see here nicely, they're all in that realm. They're not, one is not going here and one is not going there. So this is good sign for me. But when you put it under high power, which all of us do, you see that there's something not good there. And at the wall of the lesion, what you see, what I always tell all the younger people in the audience, look at the wall. If the wall of the papilloma duct is innocuous, whatever is inside is at least not invasive. It may be atypia DCIS, we'll figure that out. Now what you actually see, if you remember what I showed you, this is the adenosis-like growth pattern. And because it is adenosis-like growth pattern, and of course there is atypia, and we are very fond of nuclear atypia. You see in the higher power, but what is wrong with this atypia is that this is atypia in apocrine cells. There is no mitosis, there is no necrosis. So when you have apocrine, many times I do androgen receptor just to prove that that atypia is in apocrine cells. And second thing is, the next atypical cell actually is the myepithelial cells. So when you have atypia in different kinds of cells, there is not a cause of worry. That tells you that this is a Hafizard lesion. It is probably not a DCIS. The P63 abundant, this is the 818 and CK56. You can see that 818 is the antibody clone that we have is a little stronger clone, but they are equally distributed in that lesion. So this is not a clonal process. So the final diagnosis was a papilloma. I called it complex just to, there was a lot of repercussions around this case. This case is now 5 years old and the patient is doing fine. So the moral of the story is that when you see atypia in a papilloma, don't jump, just think about where it is, which cells it is. Another lady, microtectomy done for lipin discharge. Again, those nice jigsaw puzzle-like fronds fitting into each other. But this, as you cut the section, we entirely submit a microtectomy. So as you cut the sections, you saw a little solid area. Okay, so what? We go a little more. And again, you see that adenosis by growth pattern. But here, there's a cause for worry. The atypia is not, it is there in the little higher grade. And there is mitosis. You'll see in the next images, on the left side, I don't know, I'm very sorry, but some of these images are not well visible at the distance, to the audience behind, but there is mitosis. So now there's a problem, because I was not expecting mitosis, there is mitosis. Again, what we do is look at the wall of the cyst. The wall of the cyst is multi-layered, but not that multi-layered. It is very regular, it's essentially one layer. So if the wall of the cyst is there, this is a solitary papilloma. The atypia is there. Again, I forgot to tell you that it was both in the luminal as well as myepithelial cells. Yes, there is mitosis. There is no significance of mitosis in a papilloma, but I do SMHC and CK56. Again, you can see that the atypical cells are both myepithelial as well as luminal. So, atypia is focal, and a large part of the papilloma was benign. So we call it a complex papilloma with ADH. Now the problem is that what do you do? If you call it ADH, what happens? Nothing happens because they are just kept on surveillance. In my personal experience, we actually went back and looked 20 years of ADH in a papilloma and only one patient had a DCIS. That patient's ADH could have qualified as DCIS if I had used the WHO qualifier, but that's the only patient after 20 years she's got a DCIS. So I don't jump and worry the patient about complex papilloma with ADH. But if you are in a more litigious atmosphere, that becomes an issue. So another lady, 42-year-old, this lady is different from the two previous cases. She has multiple papillomas. She has had one excision in 2017, another one in 18, and right now this is a 2020, I think, no, 2019 or 2020 case. A little more solid looking papilloma. You can see a little benign papilloma at the end, which I have captured on the picture on the left-hand side. Epithelial proliferation, worrisome. I think everybody in the audience now is very happy, and I like to look at this like that yes, this is very uniformly atypical. The myepithelial cells are lacking in large areas. ER is strongly positive. Cyclin D1 was also positive. So I do call this as complex papilloma with DCIS. Now, such patients, whenever we have called DCIS, whenever something has been done to that patient, this is what happens. So this patient had a cavity wall revision because that papilloma was excised outside and submitted to us for pathology. And you see there is DCIS, and the DCIS was very close to the margin. Now the NCCN guideline says that 2 millimeter margin is an essential thing for DCIS. So they did a mastectomy in this patient because the patient got worried that she has an increased risk of invasive cancer. So the issue with intraductal papillomas, how to handle with DCIS is very, very variable. It's very complicated. They generally counsel you for chemo prevention because most of them are ER positive. But if it is a high-grade DCIS associated in that papilloma, you have to look for DCIS around. And if you have high-grade DCIS, then that becomes a candidate for radiation therapy. Now, essentially, most patients with multiple papillomas and DCIS, they undergo mastectomy or multiple surgeries because they definitely are at an increased risk for cancer. Now, we go to the next set of series, but before we go, there is a little small case for you. This is a 40-year-old lady. Now, this patient, again, there's a behind, I'm cutting out my stories because, sometimes it becomes very verbose. So, it was operated outside called encapsulated papillary carcinoma, and she came to us only for just a second opinion or maybe further treatment. And that was your tumor. If you look at the tumor, of course, you have a cystic wall. The tumor is entirely in the cystic wall. And if you see at the top, there is a duct within which the cyst is there. I'm really sorry, some of this little lighter photographs will not be seen because there's too much light on the screen. You see solid proliferation. Solid proliferation, you go on the higher power. Solid proliferation with little whirling of cells. Go on more higher power. You see that the nucleus is pretty okay, another tiny nucleoli. There is no mitosis. So no encapsulated papillary carcinoma will show you no mitosis. You should at least find one or them. More photographs. So we are addicted to immunohistochemistry. These days our world has become immunohistochemistry and molecular. So we do some couple of myepithelial markers. And this is the reason actually why it was called carcinoma. That the smooth muscle heavy chain complex was absent, the ERPR was negative, and the P63 was like this. Anyone would like to comment on this? Myepithelioma. So I have seen cases like this which have been called as myepitheliomas. The 5-6 was strong, but you know that 8-18 was missing, so you know this is actually a clonal population, but I did not think. Now this was the IHC that caught my eye. I always do a CK19. If you see the duct wall is very beautifully CK19 positive, but the tumor is very palely positive for CK19. Now we use CK19 as a marker for breast differentiation. As I was saying, I don't swear and tell you that, but something tells us that something about this is non-breast, and that's when you think about an alternate diagnosis. Is anybody? So this was actually an eccrine proroma in the nipple duct, and that is a unique location described. Now, there are reports like this which say that this is the first case in literature and all. I myself have seen 5 cases, but we are lazy enough to publish, so we have not done it. What actually I am presenting you this for is that then there's a nice, how when we had a skin tumor in breast, we always struggle what to do now, how do I prove, how do I go? Well, the NGS has helped in this it has shown us a nice list of translocations that are now seen in skin head neck cell tumors, some of which have been translated into immunohistochemistry. And one of the immunohistochemistry in this case that was useful, because in poric or poromas or porocarcinomas, YAP and NUT IHC is positive. I don't have experience with YAP, but we have lots of NUT, and we've already seen Kane madam cracked a few of those nuts. So we did a NUT IHC. Now I don't have the image because I'm not a very IHC person. So I just put it before coming, and the slide was wet, so they could not scan it, but the NUT IHC was positive. Just to prove that yes, it is a poroma, and the patient, there are many more IHCs if anybody would like to understand. And the clone for NUT is the same clone that you use for head and neck. Now 1 year later, we didn't do anything to that patient. 1 year later, she had again a recurrence, again in the duct, but again a very, very tiny. That's all that she had, and we are again keeping her on observation. So let's hope it does not turn malignant. Now this is a companion case I would like to show, because sometimes, we don't open our brain has to be a little wider. And when we keep doing one subject for a long time, it does become. So this is one of the patients. She was a doctor's mother and treated, everything was done, but how we are, let me just show to somebody. So that person got and showed me the slide. And he said, oh, TNBC, high grade, will give extensive chemotherapy. I looked at this and I said, no, this is not a breast cancer. Because you see, this had these tiny, tiny little, it was a small cell tumor, and you had this little lumina in this. There were areas with squamoid modules, and there was areas with squamous differentiation. And this was the 818. It was showing you very, very few in the whole tumor, which was 818 positive. Now, there was a lot of anguish because the patient had already completed some 2 of Paclitaxel chemotherapy, and because many pathologists in the city had called it TNBC, and actually this was nothing but a malignant eccrine sphiroadenocarcinoma. And the thing is, we just need to be, the patient is fine. It's now, I think, 3 or 4 years since I'm not pre-COVID era. So the moral of the story is, if you think you see an odd morphology in the breast, just open your eyes and ear. And if you see that it lacks, it's a very skin tumors are always circumscribed, and very little of them are infiltrating. They're usually that biphasic nature should sting you. And the thing is that the squamous eye lines are very uniformly placed in every skin cancer that occurs in the breast. They have a very basaloid pattern, and if you have anything, of course, they usually turn ER negative. If it's benign, they will be bland and ER negative, and that's the kind of combination that helps you put on the track. So the next one, again a little unusual histology. We just got one section for ER/PR HER2. This was a 75-year-old lady. On the higher part, what do you see? You see something different. You know that this is not something that you see normally. More higher part, that's obviously an infiltrating lesion. It's going everywhere, and the cell type is different. Does anybody wants to say what the cell type is? Yes, endocervical, foveolar, those kind, right? So clearly something metaplastic. There, a little bit of atypia, but fairly so. So obviously, what you're worried about is infiltrating. It looks different. So first thing you put is myepithelial markers. Smooth muscle heavy chain complex, P63 tells you, yes, it's a biphasic lesion. But the problem is the ER is negative. Is that really a problem? No, because it is a metaplastic lesion, and I'm expecting it to do endocervical cells normally express strong ER. No, sometimes they lose their ER. And this is a metaplasia, so I'm expecting even a benign lesion to lose ER. Now, I just want you to keep the diagnosis of the case in your mind. We are all erring on the side of benign. And I'm showing you another case, which is a companion case, again an infiltrating lesion. Here, the same, I don't know whether you can appreciate it, this magnification, but at the top corner, you're seeing the same glands, but the bottom corner is a little more solid. And this shows, this was actually called adenoid cystic carcinoma. And you see, yes, of course, if you don't see those glands, you will call this as adenoid cystic carcinoma. Here is a picture to show you this kind of proliferation and that kind of proliferation. So both these cases were similar. I actually have a series of these cases, but these are the only ones. I'm lazy, I didn't take the other ones. So this is actually infiltrating tubular adenosis. And there are reports like this which say that this is adenoid cystic carcinoma in tubular adenosis, but I really don't think they're adenocystic carcinomas. I think they are adenoid cystic hyperplasias, but again, who am I? I'm not a Tawasoli or Schnitt. So how do you diagnose tubular adenosis? That 2-layer, I think most of us will make a diagnosis of benign as long as you keep your ears and eyes open, that it's a little odd lesion. The thing is, when it comes with the adenoid cystic-like carcinoma, that is when the problem arises, because then we end up calling it a carcinoma when it may be a atypical lesion. It may not be a carcinoma. Interestingly, that one paper which I showed you, that's the only paper in literature which describes this entity, it showed that the tubular adenosis was much more complex molecularly than the adenoid cystic carcinoma. So the adenoid cystic had become a simpler when it transferred. So this is the same thing about tumor evolution and heterogeneity. As I said, CK19 is a very useful marker. It is not seen in tubular adenosis. It is seen in the tubular adenosis, not seen in adenoid cystic carcinoma, and it is always useful in skin adnexal tumor. Now, we do have the MIB fish for adenoid cystic carcinoma, and this was negative in that case. And I think if you look at the literature, breast adenoid cystic carcinomas, only 30% of them show MIB fish positivity, because I think those 30% are the real adenoid cystic carcinomas, and the 70% actually comes from infiltrating quasi-neoplastic lesions like the one that I tell you, but till we publish, I think that's just a thinking process. Now we move to the third part of that. So we finished with papillary, we finished with unusual histologies, now we move on to the bread and butter of most pathologists, and that is biomarkers in invasive breast cancer. So this was a 39-year-old metastatic breast cancer, lung and liver metastasis, fungating mass in the breast, core biopsy was done. ER negative, very high-grade tumor, you accept it. But that was the PR. You see this PR, actually, I undercalled it, much undercalled it, but it's actually all cells, but with a moderate intensity, some with a little lesser intensity. So how many of you would call this positive? Obviously, this is a slide seminar, so there has to be a catch. So here's the catch. So the issues, please understand, when we sign out these ER-PR reports, think of the patient at the end. I always look at the age of the patient. Because if she's a metastatic breast cancer, so if this is ER-PR positive, she will undergo surgical oophorectomy because she is aggressive disease. But what does PR positive exist really? So again, what happens in such cases is they always ask for a cross review in our hospital. So I was the cross reviewing person. Now when small things like these happen, they're actually the beginning of bigger things. And this was just after the COVID madness was over, somewhere in the late 20 and 21. And this actually earmarked a very big investigation in the hospital, and the results of which were very astonishing. So what I did was, I realized that these actually are false positive tests, and not just PR, we were getting even with ER. So I started a whole quality control exercise. This is a mRNA system for ER, PR, HER2 and Ki67. This is the same gene expert that we used for tuberculosis. It has a system for ER, PR, HER2. You just put the paraffin material in that cartridge, load it onto the machine, it gives you a result in 2 hours. But it's not necessarily the same as what we do on IHC, but it's a validating machine, all right. So when we did it, it was negative by strat 4, totally negative. We repeated with DECO PR antibody manually, negative. So that told us that that was false positive. But this was not the only case. We had a series of cases, and when we evaluated it, we realized that due to COVID, some of the locations of situations had changed, and the core biopsy was taking longer to reach our lab than what it was in the pre-COVID times, and these were actually all over-fixed biopsies which missed that day's deadline. They went to the next day evening's deadline, and so there was actually more than 24 hours fixation of these biopsies. So then now we looked into, I think we have corrected the process. But this is the comparison that you can see that all the low positives up to 5/8 were all negative, but that's even otherwise. And that is why there is a thought process that these low positives that we are reporting in automated platforms, some of them may not be the true positive ones. And this is a UK EQUAS paper years ago which said the same thing, that okay, I'll end here. I had one more case, I'll end here. So how much time I have? 30 minutes over? Okay, done. So they said that with this, now the antibodies are becoming very stronger. They are becoming because, we didn't have ERPR working in our IHC for a long time. So we are moving in an era of underestimation to overestimation. And this was actually a triple negative cancer. Both PR, if you use the SP1 antenna antibody, it came strong positive. So the ASCO-CAP has finally realized this, especially with ER, and it has put a caveat that 1 to 10% of ER, we have to call it as low positive and say that these could actually represent TNBCs. And my take-home message is overfixation. Now, overfixing, because all of us are doing our ERPR on cone biopsies, and overfixation has to be monitored, and such kind of ERPR results. Actually, I forgot to tell you, the staining is a little different. It is very smudgy, and it is on the top of the nucleus, but if you're not aware, so here is a case which is an operable breast cancer. She is ERPR strongly positive. She just has a 1.8 centimeter tumor, and it became 1.8 later on. That was the morphology. There were only 3 sections with the tumor because it was just 1.5 centimeter. This is one section, high-grade tumor, but you're okay with calling it as ERPR positive. Now, this was the lateral margin which was closed, and this is the tumor in the lateral margin. Morphologically little different, but if you have got a core biopsy report of ERPR positive, HER2 negative, you will move ahead. So this was the final HPR. Till the medical, I was reporting this case, but something about it bothered me, so I had not committed it. And the medical oncologist in TMH, we have EMR on which all reports, provisional reports are visible, so they very happily access the report, and the medical oncologist calls me. Hey, madam, you've not done a Ki-67, this is operable breast cancer, node negative. She said, Dr. Seema is not here, but she said, I told her, Seema, I'm not worried about the Ki-67. I'm worried about HER2. Because I think the HER2 in this is something fishy. So she was all, I said, madam, I counsel the patient that you're a good prognosis cancer, and you're telling that there's a possibility. I said, no, hold on. I will repeat the HER2. So this was the HER2 in the first area. And that is the HER2 in the lateral margin tumor. It was strongly positive. So this brings us to the era where we have to take a note that doing IHC on one section, as pathologists, we should be complete. We should understand there is heterogeneity in cancer. And this is the D-dish photographs. You can see this is the left side tumor is all of the tumor, and the right side tumor is the amplified tumor. So this formed more than 10% of the case, so we did call it positive. And so this brings us to the era. So all of us reporting HER2 new, I just want you to tell, I will end it here, there are a lot of material, but I'll end it here, that we have to understand that HER2 new heterogeneity is being increasingly found because we are, as pathologists, are becoming more aware. And secondly, there's a change in the definition of HER2 on the now. Now we have the Destiny trial that has come in, and what it has told us is that, remember those ISH positive cases, equivocal 2+, which are FISH negative. We just said, okay, negative, negative. Well, now they will be called as HER2 low. And that 1+ where there is greater than 10% of cells are staining, but not completely, which we are calling it as negative, are again going to be called as HER2 low. Why? Because you now have drug antibody conjugates where all you need is, you need the HER2 on the membrane. You don't need it amplified. So as long as there is HER2 on the membrane, there is a cytotoxic drug attached to the trastuzumab. You need HER2 on the membrane, even if it's little, the drug will go down and it will be released in the cytoplasm, and the cytotoxic drug will kill. The HER2 is just a messenger to ensure that the drug goes down. So with this, I think new era of HER2 is on the horizon. So those of who are reporting HER2, that's the end of my talk. Thank you so much.